All right. Thank you everybody for joining us today. My name is Andrea Baer, and you are joining the part 2 of the series in reducing your risk of heart disease. This webinar series is a collaboration between Mended Hearts and the American Society for Preventive Cardiology, and it's created with an educational grant from Amgen. I would like to welcome you to today's webinar, Following Your Treatment Plan to Reduce Your Risk of a Second Event. Today you will hear from me. I am Andrea Baer, the Director of Patient Advocacy and Program Management for Mended Hearts and Mended Little Hearts. I'm also a mom to a 10-year-old son with congenital heart disease. Dr. Seth Martin is a core faculty member with the Cicerone Center for the Prevention of Cardiovascular Disease and the Director of Advanced Lipid Disorder Center. Dr. Martin also serves as an associate faculty member in the Welch Center for Prevention, Epidemiology, and Clinical Research, and an affiliate faculty in the Malone Center for Engineering and Healthcare. We will also hear from Patrick Farrant, who is the Vice President of Mended Hearts. He's the Executive Vice President-elect for Mended Hearts. And he has served as a local chapter treasurer, vice president, and president. And nationally, he has served as Assistant Regional Director for the Western Region, and 2 terms as the Regional Director for the Western Region, and is currently serving his 2nd term as the National Vice President. A little bit about Mended Hearts. Mended Hearts is the largest peer-to-peer support network in the world. Our mission is to inspire hope and improve the quality of life of heart patients and their families through ongoing peer-to-peer support, education, and advocacy. We have 285 chapters across the country serving over 460 hospitals. The American Society for Preventive Cardiology's mission statement is to promote the prevention of cardiovascular disease, advocate for the preservation of cardiovascular health, and disseminate high-quality evidence-based information through education of healthcare clinicians and their patients. Prior to starting the turning over the microphone to Dr. Martin, I just would like to share that all of our attendees are in listen-only mode, which means that you are muted. Throughout the course of the webinar, if you have questions, please feel free to type them into the chat box, which is located on the right-hand side of your screen, and I will read those questions during our question and answer period. You can also raise your hand, and that will alert me that you have a question. And so during our question and answer period at the end of the broadcast, we will share, I can unmute you so you can ask your question personally. So without further ado, I would like to turn it over to Dr. Martin. And Dr. Martin, the floor is yours.
Thank you so much, Andrea. It's really a pleasure to join you. I'm thankful for the chance to collaborate with Mended Hearts and to share evidence-based information on preventing cardiovascular disease after an event, what we call secondary prevention. So really glad to be here and share my thoughts for the next 20 minutes or so, and then looking forward to hearing Patrick's thoughts and looking forward to the discussion. So thanks to everyone who's joining. You heard a little about me. I'm a cardiologist at Johns Hopkins, and I work both in the hospital on the inpatient unit where I take care of patients with a team there in the hospital, patients who've had a cardiovascular events, as well as work in an outpatient clinic to continue to partner with patients in preventing future events. And so I'll share my perspective as a cardiologist, as a clinician, share the evidence-based guidelines, recognizing that ultimately, from the patient perspective, this has to be fit into your life and figuring out really what works for you. So I think there's a lot of opportunity to kind of personalize the implementation of the evidence-based recommendations. So let's see, if I click on the slide, does this, yep. So, so the ABCD approach, this is the type of way that we've organized secondary prevention recommendations at our prevention center at Johns Hopkins. We'd like to say that it's kind of like the Jackson 5, ABC, simple as 1, 2, 3. The antiplatelet anticoagulant is what the A stands for, B for blood pressure, C for cigarettes and cholesterol, D for diabetes prevention, diet and weight management, and E for exercise education. So I'm just going to kind of use this as the structure to walk through some of the evidence-based recommendations. And I think that, this is, although in a way simplified to say A, B, C, D, E, there is quite a bit here. And so I recognize as a clinician, on the one hand, we're really lucky to have a lot of knowledge and recommendations about what we can do for prevention of cardiovascular disease. On the other hand, to really do all these things well certainly takes a lot of knowledge as well as effort to really address all these things comprehensively. So just moving to the first slide here, antiplatelet. Generally, after having a cardiovascular event, one would be on aspirin at a lower dose, 80 to 162 milligrams per day indefinitely. We generally use the lower dose of 81 milligrams. And then in combination with one of the newer antiplatelet medications, clopidogrel or prasugrel or ticagrelor, these P2Y12 inhibitors, and these are class 1 recommendations from the guidelines. If there's a bare metal stent, which has become less commonly used to open the arteries over time, then P2Y12 inhibitors would be taken for at least 1 month. If it's a drug-eluting stent placed in artery, then we're talking about a year or more of being on the P2Y12 inhibitor. And we see there, I mentioned that we generally use 81 milligrams, and that is the class 1 recommendation if someone is on dual antiplatelet therapy. If no PCI, percutaneous coronary intervention, is performed after an acute coronary syndrome event, after a heart attack, then either clopidogrel or ticagrelor should be used. We have the best data there for those therapies. There is a class 3 recommendation, meaning not to use prasugrel if there's a history of stroke or TIA, and in those who are those who are over 70 years of age due to safety issues. And then following a non-cardioembolic ischemic stroke, the recommendation is used 81 to 325 milligrams per day or clopidogrel. And it's, it is interesting, despite all that we know, we still have some level of uncertainty as to optimal dose of aspirin. And I will mention, I think with 20 minutes, it's too much to kind of get into the nuances of the different anticoagulants and when to use both aspirin and a P2Y12 in combination with anticoagulant, or to actually where there's excess risk of bleeding with all three, and then to drop one of them. So I'm not going to get into that, but just the main risk with all those is bleeding, and has to be balanced against the benefits in terms of cardiovascular prevention. So if someone has atrial fibrillation concurrently, then there's some more nuanced decision making to be made. So, but I want to keep moving on to blood pressure thresholds and recommendations. So we were fortunate to get new hypertension guidelines in 2017 from the American College of Cardiology, American Heart Association. And what we see here is that normal blood pressure on the left-hand part of the screen here is classified as less than 120 over 80. And there, it doesn't mean that one is off the hook, but just to focus on optimal lifestyle habits and to continue to reassess on a yearly basis. And then if we slide over here to 120 to 129 would be considered elevated BP, and there the focus would be on non-pharmacologic therapy, and I'm going to show more specifics there on the subsequent slides, and then to reassess in 3 to 6 months. Now stage 1 hypertension, and this is what caused a lot of buzz around the time of the guidelines, is classified as 130 to 139. And there, if one has clinical ASCVD, which is what we're talking about today, then the answer there would be yes, and we'd go to non-pharmacologic therapy as well as a BP lowering medication as a class 1 as the strongest recommendation. And then same thing for stage 2 hypertension if the blood pressure is over 140 or over 90 or more. So a little more specifics on the non-pharmacologic interventions. So these are all the strongest recommendations, class 1 recommendation in the guidelines with a level of evidence A, meaning that there's multiple randomized trials, strong evidence to support the recommendation. So weight loss is recommended to reduce blood pressure in adults who have elevated BP, who are overweight or obese. Secondly, heart healthy diet, such as a DASH diet, which was developed a while ago by colleagues at Hopkins, Dr. Apple and others, that facilitates achieving a desirable weight for adults with elevated BP. Sodium reduction is recommended for adults with elevated BP. Potassium supplementation, preferably in dietary modification, so actually getting this in the diet rather than taking supplemental pills, is recommended for adults with elevated BP unless contraindicated by presence of kidney disease or drugs that reduce potassium excretion. So there should be some tailoring there based on what one's potassium levels and kidney disease status are. But conceptually, I'd say that the statement there that it's best done in the diet rather than taking additional supplements is really something that should be considered across the board, to really try to do as much through a healthy, balanced diet rather than taking additional supplemental pills. So the next slide here, it also has strong recommendations, class 1A recommendations. Increased physical activity with a structured exercise program is recommended for adults with elevated blood pressure, hypertension. Adult men and women with elevated BP or hypertension who currently consume alcohol should be advised to drink no more than 2 and 1 standard drinks per day, respectively. So 2 referring to men and 1 to women. And you see there kind of the text at the bottom what a standard drink refers to, but it's basically a beer or a glass of wine. And so moving on, try to keep on time here. So blood pressure therapy and use of CV risk estimation. So in the secondary prevention context here, again, we're going to focus on the most intensive blood pressure therapy, and this is a class 1 recommendation. And for systolic blood pressure, we have the strongest data, less data for managing diastolic blood pressure. So using blood pressure lowering meds is recommended in secondary prevention for preventing that second event if the average blood pressure is 130 or more systolic. And so this is really just reinforcing what we covered on the prior slide. I wanted to, so much of this hinges on actually getting an accurate blood pressure. So this is a level, a recommendation 1, class 1, but actually expert opinion. But I think very important to really focus on getting good data to make good decisions regarding blood pressure management. So just wanted to review this quickly. Step 1 is to properly prepare, and step 2 is to use proper technique, and then step 3, taking proper measurements and then properly documenting this. So when we talk about the term proper, we're talking about being at rest for 5 minutes with the feet supported on the ground, with the arm at heart level supported, for example, on like a table. You're not in the midst of a phone call and you're not upset about something. And then it's often helpful to take 2 or 3 readings And what's often done in the clinical studies is to then take the last two readings and take the average of those. So I think this is something just to be, whether you're in the doctor's office getting blood pressure measured, this is something we've worked a lot at our clinics on, because often we find patients are kind of rushing in and then they're brought right back and the blood pressure is taken. And if you just wait another 5 minutes and reassess, it's often quite a bit lower. So I think this is something just to be vigilant about, whether you're taking readings in the office or at home, to really get accurate levels to then drive decision making. So I wanted to just keep the momentum going here and move on to the C's of the ABCs. And here we're talking about cholesterol. And in particular, we have by far the most data around management of LDL cholesterol levels. And this is a slide where on the y-axis, we have event rate for cardiovascular events. And then on the x-axis, on the bottom there, we have LDL cholesterol levels achieved. And we've been, since we're focused on secondary prevention today, I wanted to kind of hone in on the, you see the light blue secondary prevention and these blue trials. And over the decades, we've had the trials driving down to lower and lower levels of LDL cholesterol, below 100 and then below 70 milligrams per deciliter, and showing that the lower we go, the lower the event rate. And this is one, of all the evidence that we have in clinical medicine, this is one of the most proven links that we have through removal of LDL cholesterol in the liver using This is all about statins, this particular slide, but now we have data for ezetimibe and PCSK9 inhibitors. So let's see here. There we go. So advancing to really, we're quite lucky to have had a group called the Cholesterol Treatment Trialists that has organized all this evidence in really the most rigorous of fashions over decades to put all the statin trials together. And this includes trials that have had at least 2 years of follow-up and large numbers of patients. And if we look at 26 clinical trials involving nearly 200,000 patients and many events to understand the relationship of cholesterol and statins and risk, we find that for taking a higher intensity statin, that's better than a lower intensity statin. And if one lowers the LDL cholesterol by 20 milligrams per deciliter, then one would expect about a 10 to 15% reduction in the relative risk of cardiovascular disease, or what's commonly said, a 1 millimole per liter or 40 milligram per deciliter lowering would lower it about 25% or so. So this is one of the most well-established treatments that we have in modern medicine, thanks to this data from the cholesterol treatment trialists. So this slide here shows that the benefits accrue over time. The more years one takes statins, the more benefit that will accrue. So after having a cardiovascular event, that first year is really critical to get in the habit of sticking with medications. But the benefits of taking the statin are not yet as much as they're going to be in the subsequent years. The plaques are getting stabilized, and and by taking it in subsequent years, we're preventing new plaques from forming. And so once we get into year 1 to 2, the relative risk reduction is greater. We see going down from the first year 9%, that 0.91, so 9% relative risk reduction, now down to a 22% relative risk reduction, and so on. So I had mentioned this 25% earlier, and that's kind of the average that happens from years 1 to greater than or equal to 5. But really, the main point of this slide is the more years that that one sticks with the statin, the benefits are going to continue to accrue. This is our latest guidelines. So we're lucky to have updated cholesterol guidelines from the American Heart Association, American College of Cardiology at the end of 2018. And if we follow this slide, let's start at the top there, just seeing that healthy lifestyle, again, is considered the gold standard foundation of therapy. So that's really the start. We always want to put a lot of emphasis on the healthiest lifestyle and then using medications as adjunctive therapy to that. So very high risk ASCVD, atherosclerotic cardiovascular disease, is going to be present in a lot of patients. If someone's had a heart attack and has hypertension and diabetes, we're going to have falling into that type of category. And high intensity or maximal tolerated statin therapy we see in green there is the strong class 1 recommendation. And then what the guidelines lay out as the next step is to consider non-statin therapies. In particular, if the LDL cholesterol, and this is taken from the way that the clinical evidence was designed, the clinical trials, if the LDL is 70 milligrams per deciliter or more, it would be a class 2A recommendation, something that should be considered to add ezetimibe as a reasonable next step. And then we see, as we flow down there to the bottom right-hand side of the slide, that if on clinically judged maximal LDL lowering therapy, so if the patient's on lifestyle plus statin plus ezetimibe and the LDL is 70 or more, to consider adding a PCSK9 inhibitor as the next step. And the guidelines say to consider, because this is something that really is best done through a discussion between the patient and the clinician to decide, is this really the next best step in care, and have we discussed the risks and benefits and really have the buy-in to move forward with that aspect of secondary prevention. I think a lot of folks are going to end up in that very high risk category on the right-hand part of the slide. And for sake of time, I'm going to keep moving along to the subsequent slide. So if patients with clinical ASCVD, reducing LDL cholesterol with high intensity statin or max tolerated statin, this is really a key point. And the more LDL is reduced on statin therapy, the greater the subsequent risk reduction. And we want to try to initially get that LDL cholesterol reduced by 50% or more by using a high intensity statin like atorvastatin 40 or 80 milligrams or rosuvastatin 20 to 40 milligrams. We want to be on the most effective dose possible. And then we consider, as shown in the prior slide, the non-statin therapies. So just moving right along to the next slide. So that in that very high risk group, and there's specific criteria, and I'm not going to go through the full list of those criteria, but I think it will likely apply to many patients. And this includes if there's been basically multiple events or one event and multiple high risk conditions such as age, diabetes, persistently high blood pressures or cholesterol. And in that very high risk group, it's reasonable, again, this is just reinforcing the prior slide, to add ezetimibe when the LDL 70 or more, and then to consider adding a PCSK9 inhibitor when it still remains above that level. And there's some discussion of the cost effectiveness in the guidelines, and that's an active area of interest because there's been price reduction in these medications, which has changed the cost effectiveness assessments. The guidelines that were based on mid-2018 prices, which has now changed. So continuing to move along here to the next slide. I thought this was interesting. The guidelines are starting to shift towards thinking about implementation. I'm really curious to hear about Patrick's perspective because ultimately we have all this great evidence, we have these recommendations, but what really matters is actually providing the information, the resources, the access to patients to actually implement these recommendations in the best way possible for their own care. And so here's some of the bigger picture perspectives that the guidelines provide. Again, all class 1 recommendations. And they say that interventions focused on improving adherence to prescribed therapy are recommended for the management of adults with elevated cholesterol levels. And this is, targeting cholesterol, but I think can apply to other risk factor management areas that we're discussing today. So including telephone reminders, calendar reminders, integrated multidisciplinary educational activities, and pharmacist-led interventions such as simplification of the drug regimen to once daily dosing. They go on to say that clinicians, health systems, and health plans should identify patients who are not receiving guideline-directed medical therapy and facilitate initiation of these guideline-recommended strategies. And then before therapy is prescribed, and this is something I was mentioning earlier, a patient-clinician discussion should take place to promote shared decision-making and should include the potential for ASCVD risk reduction, benefit, adverse effects, drug-drug interactions, and patient preferences. So really, rather than the clinician just saying, here, go take this, it's really a matter of actually having the discussion about why one would take this, understanding the benefits and risks, making sure there's not interactions with other drugs, and really understanding whether this fits with the patient's goals of care, and really setting the stage for more effective partnership between the clinician and patient and long-term adherence. So as I get towards the end, I just wanted to have one slide on diabetes management, because this is a really exciting area where new drugs are being developed, and we have much more options here, because these new drugs actually have been shown to improve cardiovascular outcomes, which is something new in the diabetes area. So this was taken from a recent review article in the Journal of American College of Cardiology from a consensus group that really emphasized the importance of addressing diabetes and clinical ASCVD concurrently. And guideline therapy, there you see on the left, includes the things we're talking about with antiplatelet, blood pressure, lipids, and glucose lowering with the classic medication that's been around for a long time, metformin. But now, considering new medications, specifically SGLT2 inhibitors and GLP-1 receptor agonists with demonstrated cardiovascular benefit, and we again see this importance of the clinician-patient discussion to make a shared decision around these medications. So I'm not going to get into details of these medications, but I felt that we really needed to bring to the surface that these are now available. And wanted to circle back to the critical importance of diet. So these are recommendations that haven't really changed a lot over the years, but remain critically important. So balancing calorie intake and physical activity to achieve or maintain a healthy weight, focusing on fruits, vegetables, whole grain, high fiber foods. If considering fish as a source 2 times per week or more, limiting saturated fat, and not saying removing all fat from the diet, but trying to replace that saturated fat with unsaturated types of fats, and limiting cholesterol intake. So choosing lean meats and vegetable alternatives, fat-free dairy products, and minimizing hydrogenated and trans fats. Avoiding, colas, sugary drinks, choosing and preparing foods with little or no salt, really trying to do as much home cooking and having as much control over your diet as possible. And minimizing alcohol to the levels like we discussed in the blood pressure recommendations earlier. I'm going to keep flying through because I don't want to take up too much time. Hopefully we have time for discussion at the end. So for recommendations for physical activity, the minimum is 150 minutes per week of moderate intensity activity, which basically means something like brisk walking. And then it can be 75 minutes of more vigorous types of activities, or some combination of these. Ideally, episodes of 10 minutes or more, but anything counts, and really spread throughout the week. Just cruising right along here. I just wanted to briefly mention how important I think education is, and mention that at Hopkins, we've been working for the last few years to develop a patient-centered smartphone app that delivers really powerful videos like this, much better than any drawings I could do, to really empower patients with the knowledge that we believe will help with following recommendations after having an event. So this app includes education, but it also serves as a tool to track medications and vital signs, schedule follow-up appointments, serves as a medical wallet to store critical information. So this is called the Corey app, and this is something on another day I would love to get feedback from any interested patients about the directions we're taking with this app. But education is really a critical centerpiece of this approach. So thank you so much, and I'll be staying on, looking forward to Patrick's comments and looking forward to the discussion with the group.
Thank you so much, Dr. Martin. I appreciate that. Now I'd like to turn over the presentation to Patrick Farrant. And Patrick, I will give you the floor.
Thank you, Andrea, and good morning. I should mention, obviously, I'm a heart patient, having been through a heart attack followed by a surgical procedure, open heart surgery. I'm a cabbage guy ×3, and subsequently, or following that, I've also had 8 drug-eluted stents. So you might say I have a tad of atherosclerosis, and over the years have been trying to control this. So as Dr. Martin points out, mainly what we're after here is secondary prevention. And to do that, we need to accept right at the outset that we have a chronic disease that can't be cured, but it can be managed. And the management part always leads to reducing the risk of another event. And in these areas, so we're talking about some of the things that we can control, all directed to obviously a healthier lifestyle and making choices that will all reduce that risk. I'm not sure what slide this deals with, but I attended a session on statin adherence to prescribed statins at the American College of Cardiology, and I heard some very disturbing statistics that heart patients, by and large, do not have the greatest records of adhering to prescribed meds. 20% evidently of patients upon being discharged from the hospital don't even fill the first prescription. And then a year later, it's up to 50% aren't taking their prescribed meds. So this is, it's very, very unsettling to realize that they probably don't realize that they're putting themselves at risk. Some of the reasons might be, and obviously we do not have the benefit of having like a Dr. Martin presentation on with our own cardiologist. They just prescribe the meds, and they probably assume, I guess, that since they're the doctor and they prescribed it, but that we'll all adhere to it. So what are maybe some of the reasons why it's very complex as to why people don't take drugs? But as opposed to say pain management, if patients are taking meds for pain, if they stop taking those, they're going to notice something right away. If we stop taking a statin drug or a beta blocker or something like that, we don't notice any change right away. So maybe that's what they're thinking, but they don't understand that they're really increasing the risk by stopping these meds. So do I switch these slides, Andrea, or? Okay. This is the area that I'm going to probably talk about in terms of what we can control the most. In the education area, we were likely surprised by, and then until we found out there might have been some heredity involved, some family history when we had our event. But we now, it's our responsibility to learn what it is that we're dealing with and what can we do to cut down this risk. And there's many sources available in terms of patient education. There's a lot of material on the internet. There's support groups like Mended Hearts that have presentations from doctors about what we can do. what it is that we're dealing with, how it can be treated, and again, cut down the risk. To my way of all of the elements that where I made a change in my life by a long way was with exercise. I never really exercised a day in my life before. And in terms of what motivated me, it was at the end of the rehab program, the nurses said, will you continue on with an exercise element? And I said, sure, I will. And they said, well, when are you going to do it? And I would say, well, when I come home from work, you know, and they would say, you know, we're students of behavior, and that's not likely to happen. You come home from work, you're tired, you might, you know, read the old-fashioned mail, or the nightly news might come on, and then you have dinner, and then maybe your favorite TV show comes on. What they pointed out, and it really impressed me, is they say, unless you get up half an hour earlier, this is not likely to happen. And it's not that you're a morning person or whatever. You just have to get up early and do these exercises. So I've been doing now 30 minutes of on a recumbent bicycle, 30 minutes a day, 5 days a week, and I've never felt better. It's really made the biggest change. I remember, in terms of the value of exercise, this one cardiologist pointed out, knowing that we visit heart patients, said, you know, you tell, especially males can react or respond to automobile analogies. And he just used this example of saying, you know, the human body is a lot like a high mileage car. It's all paid for, but when you have a lot of miles on a car, you understand there's going to be some maintenance issues. Things are going to wear out, like belts and hoses and tires and batteries and things like that. In these days with modern medicine, things on the body are wearing out, like knees and hips that are being replaced. Most people think that exercise is for young people with highly toned bodies, maybe athletic, competitive. Just the opposite is true. As one ages, there is more of a need for exercise than for a young person. Just like a new car needs almost no maintenance, just change the oil, where an older car needs a lot of maintenance. So that really struck with me. Obviously, the heart is a muscle, and that's the need is to get the elevated heart rate up for ideally 30 minutes a day, 5 days a week, and that just makes a tremendous difference. Behavioral changes, well, the obvious one, and in this era that we live, a lot of people are no longer smoking, which is a tremendous benefit for the heart. So that goes without saying. That would be the number one thing to change. But then Dr. Martin also talked a lot about the diet. And here, I think that the people that I've spoken with are very reasonable about diet. They just talk a lot about balance and especially reducing sodium. You don't want to be, you know, sodium thickens the blood, makes the heart pump harder. So you just lose your taste for salt over time. We don't cook with it anymore. We use Mrs. Dash and Herbal. Doctor told us just to put 2 pepper shakers on the table, no salt shakers. Don't put it on food. Mind you, you can't avoid it. Its sodium is in anything that's canned or boxed, as it's a preservative. But they've turned me into a label maker. I was just shocked sometimes in shopping. I just looked at what would be some examples. I used to like rice-a-roni. I looked at a box of rice-a-roni. My God, 1,900 milligrams per serving. Right next to it on the shelf was brown rice, 100 milligrams per serving. One other example that I remember, that I was looking for salad dressing, and it said Paul Newman's balsamic vinaigrette, and because it said Paul Newman's, you know, healthy all over, no cholesterol, no fat. You looked at the 900 milligrams per serving. Right next to it on the shelf, Paul Newman's oil and vinegar, 150 milligrams versus 900. So they just said, you know, open your eyes, you'll be surprised. Another really a bad one is any kind of canned soup, where on the other hand, homemade soup is great for you. but canned soup is the worst with all the preservatives in it. So again, with diet, they're kind of reasonable. They asked me if I liked Italian food. I said, oh God, I love Italian food. They said, that's fine. Order it with, order any Italian food with tomato base, with red sauce, not white sauce, the starchy stuff that's going to clog up your arteries again. Order it with red sauce, which is tomato based. It's good for you. So again, it's a matter of balance. They say, you know, you get the example of shopping around the outside of the grocery store where the vegetables and the fruit and the dairy are. It's all the inside stuff with the cans and boxes that aren't any good. So those are the main areas I wanted to cover. Was the again, the exercise and the diet and the adhering to prescribed meds. These are the areas that we can't control, and can make a great difference in you know, it's just, again, I feel heart patients are so lucky we get our lives back, and then we can take control of things to reduce this risk. I'm not, in terms of the routine or reminders and apps that are available, I know there are a number. I've just been, it's so much into my routine now, I really don't have to think about getting up in the morning when the alarm goes off to do the exercise or make some diet changes. And I do, but there's all kinds of techniques, keeping a journal, things like that. There's different ways to, whatever, you know what motivates you by now to develop a positive habit. So I just would leave it up to whatever works best for you. What's the next slide? Get support from others. This is, especially initially upon being discharged, this is not a good time to be alone. You know, you get a lot of sympathy when you're a heart patient, and people might say, how can we help? What can we do? Have them come over and take you for a walk. Initially, you have to walk. It's the best to recover from the chest wound is the main thing. But it's good to be around people. This is a great time to have family around, and realizing that the lives of caretakers are also impacted by being in the relationship with a loved one who is dealing with cardiovascular disease. Can be very supportive. Their lives are affected. And there's other support groups, like Mended Hearts is one. When we often have meetings, when we get together, we said, you know, we never knew each other before the event that brought us together, so we didn't know what we were like. And we would say, what observations do you have of yourself, of how you changed? Or maybe as your loved one here, what have they observed about how you've changed? And there's a pretty interesting pattern of answers that come back. Some of them are along the lines like, well, they find themselves being far more grateful than they ever were. They're just much more thankful, and also that they're thinking more in the short run. They just enjoy every day. That, you know, let's face it, we're survivors. We've been given a second chance, and they just don't worry too much way down the road in terms of long-term planning. They just enjoy each moment. They live in the moment. They're, you know, I guess this mindfulness that you hear about is really embraced by heart patients to get through it and get the support from organizations like Mended Hearts and family and others to, you know, we've had a scare, we've come through it, and let's go on from here and be grateful that we've come this far and have we've recovered and we're recovering, but we made it, and we just celebrate things at every opportunity. I'm not sure, is there another slide, Andrea?
No, I think this is the last one.
That's the last one. Yeah, it's a marathon. Yeah. Be careful about running marathon races with heart disease. But anyway, and you know, when you say make mistakes, I mean, yeah, we might fall off our regimen of exercise. I certainly would do everything not to fall off any kind of adhering to prescribed meds. These are just these statin drugs and beta blockers and other things just get great results. They're like the miracle of aspirin in terms of how good they are, and you don't have to talk yourself into wondering what's the benefit of continuing to take this? I just don't see any change. It doesn't seem to do anything for me. Well, you might not realize all the good it is doing, and Dr. Martin has all of the, the evidence there, showing the slides with the data of how this helps us live longer and healthier. I guess that's it.
Thank you so much, Patrick. I appreciate it. I just want to make a note for everybody before we move into the question and answer period that the next webinar in the series is on May 2nd at 12 noon Eastern time. And this one will be on blood pressure control to reduce your risk. And so we'll dive a little deeper into controlling the blood pressure. Any more information on all of the additional webinars and to register for them, it can be found on our website at mendedhearts.org. There is a link on the homepage to the risk reduction webinar series. And so at this time, I would like to open up the floor for questions. And I have some questions that are already in the queue, and I will be asking those questions of the speakers today. And then as we go through, if you would like to ask another question, feel free to type it in or raise your hand. The first question I can answer, and I can provide a PDF of the slides as well as the recording to the slides after this event is finished. The next question is, can you address problems with withdrawal from some of the blood pressure medications on the market? That might be for Dr. Martin.
Yeah, I think that question may be related to this class of medications, the ARBs, where there's been some issues with the manufacturing of those medications. And I mean, it's upsetting that that's occurred, but I'm glad that it's being heavily investigated and dealt with by the FDA. I just recently received a link that has actually specifically medications by manufacturer listing the safety of them and which ones have been found to have issues and not. So Andrew, I wonder if I could share that link with you and it could be disseminated to any of the attendees that are interested.
Yeah, that would be great. Thank you.
Okay.
Excellent. Okay, so the next question is, given the changes in clinical guidelines, I'm still confused about my blood pressure, what my blood pressure should be. As a 72-year-old guy, no heart procedures yet, but a bad family history. How do I determine what's right?
Yeah, I guess to try to keep things simple, I would say you want it under this top number, the systolic blood pressure, you want it under 130. That's really the goal. And what that basically means is if your number's in the 120s, that's in a really good spot. Now it is something to personalize. If actually you're having some symptoms, feeling lightheaded with that type of number, it's something to definitely discuss with your clinical team and figure out the right number for you. But the simple answer is you want it in the 120s, the top number, the systolic blood pressure.
Great, thank you. This question is for Patrick. It says, everything that you have been through medically, your optimism and sunny outlook comes through very clearly. How important was a positive attitude to getting healthy and staying healthy?
Well, I'll tell you where I developed this positive attitude. Again, was a presentation from a cardiologist in Florida that informed us of the results of two studies. One was a 30-year study of heart patients, and the other was a 20-year study following their lives. Groups were roughly divided into two groups, optimists and pessimists. Now, who do you think lived the longest? Well, it was obviously the optimists, those that have a positive attitude, believe they're on this earth for a purpose, and just look at the the upside to life. Now, mind you, there's a medical component to the pessimists. The pessimists would say, I don't see much value in taking these drugs. I don't know it's any different, and they're expensive. I think I'll just cut back on that. Or they say, when it comes to diet, you only live once. What the heck? Let's have steak every night, and well, that's an extreme example, but put salt all over it, and we want to enjoy food. We enjoy it a lot, so I'm not making any changes there. Exercise, oh, what a pain in the neck. I'd rather sleep in. Who wants to do that? So pessimists, would maybe justify following into some bad choices and bad habits. Optimists lived the longest, significantly longer. And there was a subset of optimists, he reported in these statistics. Now, again, these are cardiologists reporting on, not exactly a medical topic here about longevity and life expectancy, but those that lived the longest were also the ones that had spirituality in their life. They just believe that that there will be another life, and that they just had a strong belief system. But again, I we feel I just love being around heart patients, because we've had we've come through a scare in our life, and it caused us to stop and think for a minute and say, boy, with the time I have left, how can I give back, or how can I help others? I got through this, and what changes do I need to make, and what avenues are available to me to help others? And in my case, Mended Hearts was one example. I also did a little work with the American Heart Association. But it's just, but in giving back, we've just we just feel so much better as well. So it's been I'm not saying it's a great thing. I mean, when I was lying there in the hospital after I was told I was down to my last 2 hours, and they did emergency surgery at midnight. So to me, every day then is just wonderful.
Thank you. Thank you so much. The next question is for Dr. Martin. Are there things that clinicians can do to make the heart patient's medication regimen less overwhelming? Fewer drugs, fewer doses, less complex? And should the patient ask for those things?
Mm-hmm. Yeah, the patient definitely should ask for things, in my opinion. I love the more a patient's engaged in their care, knows their medications inside and out, and is informed. I love that. So I would love to kind of get that question from a patient about how we could simplify it, and if they have a specific suggestion. So for example, with beta blockers, sometimes the beta blocker medication can be twice a day, but there are once a day formulations of it. So that's something that could be considered to simplify the medication regimen. With respect to, there also are some like combination pills with blood pressure therapies that could be considered. So if you're looking to simplify it, that's one thing. Another area like to think about simplification is if you're taking like a bunch of these over-the-counter supplements with this vitamin or that. I think it's one area to kind of look into it yourself, how valuable those supplements really are, and talk with your clinician about them, because you might be able to cut some of those things out that aren't really, that you may be just really basically having expensive urine from those supplements, and they're not really contributing to your health care, your cardiovascular care. So look at whether you really need any of those extra supplements. So I think those are there's more I could say, but I'd say, yeah, look at things where you could go from like a twice a day to a once a day medicine, or if there's any opportunity to kind of combine medications into a combination pill.
Great, thank you. And this question is also for you. What is your guidance on quitting smoking? Do e-cigarettes help, or Chantix type medications?
Yeah, great question. In terms of e-cigarettes, that's a very hot topic right now, and there's a lot of research looking into the safety of e-cigarettes. What learned so far is that they're not really as safe as maybe they had been kind of billed to be, and so I would say don't use those as a cessation, as a smoking cessation aid. It would be kind of my blanket statement with respect to those. But in terms of quitting smoking, this is an area where I think kind of finding your motivation to do it. I mean, it really starts with that motivation. Of course, it's different than exercise, but I was just really struck by Patrick's comments earlier, where he figured out like the way to do it was to get up 30 minutes earlier and build it into his habits. And so I think like quitting smoking is a very personal thing, where it's kind of starting to like figure out what are my triggers, why am I motivated, who in my family or friends can help me do it, and like being very open about your desire to do that. I think that's where it starts. As a cardiologist, it's my job every time if I have someone who's smoking in the office to ask them, you know, if they're still smoking, to ask about if they want to quit, what their level of motivation is, and to try to connect them with resources. I'm pretty sure throughout the country, this is a free resource called 1-800-QUIT-NOW is a phone number you can call. And there they have experts that are there, again, I think as a free resource to kind of coach you through quitting smoking, to set a quit date, and also to then think about supplemental things like nicotine patches, but also medication therapies like Chantix. So that would be some of my comments. I'm actually curious if Patrick might have some comments too, based on other patients he's spoken with that have been successful.
Personally, I was lucky. I was not a smoker myself, so I didn't have to go through that. And but I mean, where I can sympathize, if you will, is my wife was a smoker, and I just saw so many efforts or so many attempts to stop smoking. It's really difficult, and there's just help is available, and just, you know, if you understand the medical implications of nicotine, etc., and just say, you know, I can't do this myself, and just get help. There's all kinds of sources. Dr. Martin has mentioned one or two, but there's others out there. But I just personally haven't fought that battle, but I've seen how difficult it is, so I understand.
Great, thank you both. So we have time for one more question, and I have someone who has their hand raised. Andrew Tershak, I am going to unmute you, and I will allow you to answer your question or ask your question. You should be unmuted now, Andrew.
Yes, thank you. My question deals with rest and ability to sleep. You know, I'm a person that has trouble sleeping, and I don't like taking sleep aids, but I'm wondering what the recommendation is for, you know, getting enough sleep every night, and whether sleep aids are okay to use.
That's a great question. I'm happy to give some of my thoughts there as a cardiologist, recognizing that I'm not a sleep medicine expert, and there are sleep medicine experts who I think probably give a better answer than me. A sleep aid could be very reasonable if needed, but you know, and in your case, you may have already done all these basic things, but some of the things to do just before using medicine to help with sleep would be to do kind of some what I think the experts refer to as sleep hygiene. And by sleep hygiene, that means like getting on a regular schedule, trying to go to sleep at the same time and get up at the same time. I know this is not always possible if you're traveling or other things, but also to turn the lights down to a dimmer level at night, to try to avoid watching TV and being on, you know, the computer or phone and things like that, you know, instead like reading, you know, under the candlelight or something, so that you in a more kind of calm atmosphere. And also, I think it does tie back in what Patrick and I were discussing earlier about exercise and making sure exercise is part of a regular part of your daily habits, because I think that can help condition the body to sleep better. But those would just be some of my initial thoughts on that. But there are folks that specialize in sleep medicine, and I think, if you have a really difficult situation, it could be worth a visit, setting up a consultation with with a sleep medicine expert.
Great, thank you. And I also have somebody from the audience who said that to find out about getting a sleep study because you may have some sort of need for a CPAP, and so maybe seeing a sleep study doctor would be important in that aspect. And thank you, Mr. Howard, for sharing your insights on that. I appreciate it. So we are out of time. If there are any other questions that you have that weren't addressed, you can feel free to email me at andrea.baer@mendedhearts.org. And I will also get the answers to the questions that you have if we weren't able to field your question today. I would like to thank our presenters today, Dr. Martin and Patrick Farrant, for sharing your time with us and your experience and education, and I appreciate that. And I would also like to thank everybody for joining us and taking your time out of your day. Don't forget, May 2nd will be our next series in the webinar, and I will talk to everybody then. Thank you and have a great day.